So good night, everyone. My name is Sabrina Ali. I'm a house officer stationed at Port of Spain General Hospital, and tonight we'll be speaking on stereotactic radiosurgery application. So our objectives tonight include a brief history, indications and types of stereotactic radiosurgery, the benefits and its complications, and tonight we'll be going into directly what is stereotactic radiosurgery. So stereotactic radiosurgery is actually a method, of stereotactically applying a very specific and precise but a highly concentrated dose of this radiation to a specific target, and this is done via an array of non-parallel radiation beams. So stereotactically basically means three-dimensional, and these beams are generally single fraction. So they are weak beams, but very specific, and they're concentrated to a small area in the brain to promote treatment. So when was this actually introduced? It was actually very recent, in the 1950s by the Swedish neurosurgeon Dr. Lars Leskel. And what he realizes after the first clinical and successful obliteration of arteriovenous malformations that was done in the 1960s, the application of stereotactic radiosurgery application was revolutionized, and it now includes most commonly the treatment for brain tumors and brain mets as well. So in this study, what he realized is he followed up these patients for a 6-month period after the application of stereotactic radiosurgery, and they realized that there was actually no patient mortality and very little patient morbidity as well in terms of the length of the hospital stay or the complications that would happen after the typical treatment, which is craniotomies. So what are the characteristics of stereotactic radiosurgery? It's single fraction radiation, and it's typically more than 5 grays per fraction. And grays is the unit that we use to measure radiation. So basically, what 1 gray is equal to 100 radiation, and we generally give more than 5 grays per fraction in a single fraction radiation setting. The target diameter of these tumors or malformations must be less than 3 centimeters in diameter, and the delivery accuracy is up to less than 1 millimeter. So all of this is just so that our goal can be achieved. And what is our goal here? We want to maximize the target dose while sparing the normal tissue in the brain. So some of the indications can be classified into tumors, which is what it's most commonly being used for right now, vascular lesions, and functional disorders. So the tumors can be benign, could be malignant, primary, or metastatic. We could have vascular lesions such as arteriovenous malformations and cavernous malformations, and the functional disorders such as trigeminal neuralgia, intractable or chronic pain, epilepsies, and even some psychiatric diseases. So what is the mechanism that stereotactic radiosurgery has on the cells? So it targets DNA replication, which is the G2 or the M phase in the DNA cycle. And this is the most critical form of DNA damage because the strand itself breaks. So it's very difficult for the cells to repair after the replication failure happens. And the endothelial cells in the vascular they undergo apoptosis, and this directly leads to hypoxic necrosis of the tumors itself. So in terms of intracranial tumors, the primary benign tumors, which is our meningiomas, the most frequent primary brain tumor, the treatment of choice is generally resection, but stereotactic radiosurgery is actually indicated for the tumors that are unable to be completely resected. And this can be due to either its proximity with both vascular or neural structures or the reoccurrence that can happen post-resection. For our pituitary adenomas, which comprises of at least 10 to 20% of all of our intracranial tumors, and we know they are classified into functioning and non-functioning. But with respect to stereotactic radiosurgery, it offers the tumor control for both types. However, we do see a higher dose of this radiation being necessary to achieve remission for the functioning tumors. So dealing with our metastatic disease, intracranial tumors, we all know brain mets is the most common form of brain tumor, and it develops in at least 20 to 40% of all of our cancer patients. So post-operatively, stereotactic radiosurgery of unresected Mets, they did show they have equal survival, but these patients have better cognitive function preservation, which is ideally important for our patient because we do want them to have a better quality of life at the end of the day. So there are some guidelines. The radiation therapy oncology group guidelines classify the tumor size and the stereotactic radiosurgery dose of radiation that can be given, sorry. So for tumors that are less than or equal to 2 centimeters in diameter, we can give up to 24 grays of radiation. For the tumors that are between 2.1 to 3 centimeters, we give up to 15 grays. And generally speaking, tumors more than 3 centimeters are institutionalized based or clinician based treatment, but we can give up to 18 grays of radiation. And with respect to the tumor location, the stereotactic radiosurgery dose is also classified via this oncology group guidelines. So for tumors that are located in the brainstem, we give it up to 12 grays. Optic nervochiasm, which is very critical structures, up to 8 grays, vestibular schwannomas 3.5 to 5, and spinal cord tumors up to 12.5 grays. So for primary malignant tumors like the gliomas, they don't often meet these criteria for stereotactic radiosurgery. And why? Because they are not normally well circumscribed, they are not normally less than 3 centimeters. So these decisions are often clinician or institutionalized based. So with respect to our vascular lesions, arteriovenous malformations, as we all know, they are congenital vascular anomalies, and they comprise of abnormally constructed shunts from high pressure arterial input to the low pressure venous systems. All of our patients with AVMs are at an increased risk of rupture and subsequent intracranial hemorrhage. So for arteriovenous malformations that are less than 3 centimeters, they can be best treated with stereotactic radiosurgery. And what happens is the radiation induces the endothelial cell damage, smooth muscle cell proliferation, and thickening of the vascular wall. So it eventually obliterates the lumen of the AVMs. But the median time for this total obliteration does happen over approximately 30 months. So for the cerebral cavernous malformation, this is a vascular anomaly that comprises of blood vessel devoid of muscular and elastic tissue, and our dural arteriovenous fistulas, which is fistula within the dura mater, where the meningeal arteries will channel the blood into the dural sinuses. Treatment is very limited, but it still is reserved for high-risk cases, especially those patients that are unfit for surgery, basically. In terms of our functional disorders, we have trigeminal neuralgia, which is the severe paroxysmal facial pain in the trigeminal distribution. Microvascular decompression is the preferred treatment, but we do see stereotactic radiosurgery as a treatment option for these patients who are, again, not suitable for surgery as well. So what are the two types? So we can classify it into photon beam and proton beam. And photon beam, which is the gamma knife that was actually created by Dr. Laskell himself, and the linear accelerator system, which is actually being done in Trinidad, as I recently found out, and well, our proton beam. So proton versus photon. Photons deposit the energy on entrance into the tissue, and they continue depositing this, but at a decreasing amount as they travel through. But protons, they have a shorter, more bounded range of penetration, and these particles increase energy deposition at the terminal depth of penetration, which is our Bragg peak effect. So when we're thinking of stereotactic radiosurgery, we're thinking of a procedure, and we basically go through a checklist. So we have to have the placement of the stereotactic frame, which can include pins or it could be frameless. We have to obtain the imaging system via CT, MRI, angiography, or PET scans. We must be able to define our target and treatment plan, and this is basically done via multimodal approach. We able to tell the number of isocenters, placement and the length of the arc, number of beams, the beam site, and the weight, and then we execute with our radiation treatment delivery. Sometimes, generally, the patients tend to come a day before the procedure to prepare, and they are actually discharged, if not the same day, maybe the next day of the procedure, depending on if they develop any complications post or not. So this is a picture of the frames that we use. The one to my left would be the frame system where they have 4 pins that are attached to the patient. It is a bit more invasive than the one to my right, which is the frameless system. The frame system has the advantage of being offering the least mobility for the patient, whereas the frameless has the advantage of being least invasive, but still has that mobility aspect for patients. So let's deal with Gamma Knife. The energy source for the Gamma Knife will stem from the cobalt-60, and this is done in a circular collimation. So it basically produces a spherical or roughly spherical dose, and it converges at our isocenter, as you could see in the target on my picture. The precision of this Gamma Knife surgery is less than 0.5 millimeters. The linear accelerator system, the source is from X-rays rather than the cobalt-60 as my previous Gamma Knife. It is more useful for the larger tumors, and it's combined with motion tracking, so we have precise targeting as well. And our proton beam therapy, as we know, protons are positively charged, so they directly deposit their energy at the tumor site, and it spares the healthy tissue, which is extremely useful for sensitive areas such as our brainstem and optic nerve when we want to treat these tumors that are located here. So there are some clinical complications that can happen immediately, especially with the frame system. We do see some pin site bleeding and pin site infections that can be managed appropriately. And we do counsel patients on headaches, nausea, and vomiting as well. Dealing with the major complications, we do see some radiation necrosis with tissue edema that can be treated with corticosteroids. In 5% of the patients, they can have premature venous thrombosis where they produce venous hyperemia and intracranial hemorrhage. So patients are counseled appropriately. And in 1% of patients, we actually noticing some cranial nerve deficits where the small nutrient vessel and the Schwann cells of the paracellular tumors are damaged. And there have been instances of rare radiation-induced astrocytomas as well. So some of the benefits versus limitations. Now, benefits will include obviously minimally invasive. These patients have the options of doing this as an outpatient, and they not only have a low morbidity, but low mortality as well. In terms of the limitations, they do have a delayed response to treatment, as we can see from the arteriovenous malformations time for the complete obliteration. They are exposed to radiation therapy, radiation as well, and we do have some size constraints as we not really applying stereotactic radiosurgery to tumors more than 3 centimeters in diameter. So in summary, stereotactic radiosurgery is a good non-invasive method of treating a wide range of neurosurgical pathologies. And what we aim to do is reduce both the morbidity and mortality of these patients. It does play an effective role in the treatment comprehensively of the patient, not only as a sole treatment, but as part of a multimodal plan as well. So these are my references. Any questions are now welcomed.